I would now like to invite Dr. Sayan Paul to take over this session and introduce himself to the group. And thank you. Over to you, Dr. Paul, sir.
Yeah. Good evening, all. Thank you very much. At the outset, I want to thank our publisher, Walter Kluwer, and all the contributors of the book who are today participating in this event as faculty and panelists. And also many thanks to all the participants who have taken out their time to attend today's session. So today we'll be having two sessions. First session will be year in review in gynecological cancer, lung cancer, prostate, head and neck, and CNS. 10 minutes each. We'll be discussing all the important and relevant articles that was published last year. And then we'll have a panel discussion on COVID-19 and cancer care in India with our esteemed panelists. So in between, we'll be launching our book also, the Bethesda Handbook of Clinical Oncology, South Asian edition. And without much delay, let me invite our first speaker, Dr. Indu Bansal. Dr. Indu Bansal is Director and Head of Narayana Super Specialty Hospital, a Radiation Oncology Department in Gurugram. So she will be talking on gynecological malignancies. Dr. Indu Bansal, please.
Good evening, everyone, and a very warm welcome to all the attendees and the speakers. And I would like to extend a very warm, a heartfelt thanks to Sayan for making me a part of this book. So this is a really a proud feeling, and I've contributed to the gynecological section. And so this book is basically Bethesda Handbook of Clinical Oncology, and which has been written by James Abraham and James L. Gilly, and Sayan is the editor, and the Southeast Asian. This is the South Asian edition, which is adapted for local practices, conditions, and therapeutics. So now I will be speaking mainly about the advances which has happened in gynae oncology because of shortage of time. I would be discussing mainly two papers, and if the time permits, then maybe the third one as well. So may I please be allowed to share my screen now?
Dr. Bansal, you may write too. Yeah, thank you so much.
Yeah. Give me a second, I'm just adjusting it. Yeah. So is the full screen visible to all of you?
Yes, ma'am.
Okay. I'm not able to minimize this box. This box, I don't know how to minimize it. Okay. Yeah, so it's nice. Thanks. Basically, I will be talking about what should we adopt in gynae oncology. In two papers. The first one is radiation therapy for cervical cancer, executive summary, and this is as clinical practice guidelines, which was published just recently in April 2020. And the purpose of this guideline was to review the evidence, and it provides recommendations for the indications and appropriate techniques of radiation for non-metastatic cervical cancer. It includes squamous cell carcinomas and adenocarcinomas, and it does not include rare histologies, non-invasive disease, or palliative treatment. And this was developed in collaboration with AB, ASCO, and SGO. So this is a cervical cancer management algorithm, which has been provided by ASCO, and it basically recommends that any patient with below stage 1B2 surgery should be considered, and beyond 1B3 to 4, means more than 4 centimeter tumor, then external beam radiation plus cisplatin concurrent, followed by brachytherapy boost is to be given. I will discuss this this detail.
Ma'am, your voice is not audible.
Sorry?
You are not audible that much. So can you just speak a little louder?
I'm on full volume. Okay.
Okay, great.
No problem. So this is one slide, which is a take-home slide, I think, which is in which I've tried to depict the management of cervical cancer, and it in fact includes the management of the surgical part as well. So this diagram is in the book, and I will be sharing my slides with all of you, so you can go into the details of this master slide for management of carcinoma of the cervix. Now coming to the guidelines. So basically 5 questions were addressed. Question number 1 was, in which patients after surgery should you use post-operative radiotherapy, and in which patients should you use chemotherapy as well? So it basically said that for high-risk features as positive margins, positive lymph nodes, or if parametrian involvement was present, then adjuvant chemoradiation has to be offered, and whole pelvic radiation dose could be 45 to 50 gray and concurrent cisplatin 40 milligram per meter square. This is a strong recommendation, and the quality of evidence is also high. While for intermediate risk features, if you add on adjuvant radiation, it leads to 47% reduction in the recurrence risk and 12.6% absolute reduction with acceptable morbidity. In fact, if you add radiation, then the morbidity is 6% versus 2% grade 3 or grade 4 side effects. And adjuvant radiation is 45 to 50 gray, 1.8 gray per fraction. And chemotherapy may not be added in this, and the SEDLIS criteria has been used. And these intermediate risk features have been taken from GOG 92, which included 277 patients. And in fact, Cochrane database meta-analysis 2012 is also being used, and this is a strong recommendation. Quality of evidence is high. If a patient has underwent a total hysterectomy and occult cervical cancer is detected after that, then how to manage these patients? So basically, if the patient is more than stage 1A2, then additional surgery is needed. It could be radical hysterectomy plus lymph node dissection, or addition of parametrectomy, upper vaginectomy, and lymph node dissection, or RT can be given if surgery is not feasible, or if RT is already indicated as per histopathological report. So pelvic RT 45 to 50 gray with boost with brachytherapy or external beam radiotherapy at site of occult disease, and depending on risk features, concurrent chemotherapy may also be added. Now the second question was definitive RT with when it is appropriate to deliver definitive RT with and without systemic therapy. So basically for patients with stage 1B, 3 to 4A, you have to use pelvic radiation plus concurrent cisplatin and brachy boost. In fact, addition of concurrent chemotherapy leads to 10% 5-year overall survival benefit. And if you are using extended field RT, means you are doing para-aortic lymph node radiation, it is preferable to use IMRT. Monitor the blood counts, and good supportive care is a must. If you are using extended field RT, then don't give more than 5 cycles of chemotherapy. The dose recommendation is 45 to 50 gray, 1.8 gray per fraction with concurrent cisplatin 40 milligram per meter square, and limit the total treatment time to 7 to 8 weeks. It's a strong recommendation, and the quality of evidence is also high. Now, one more question which was addressed is, should we do hysterectomy after radiation? So in stages 1B, 3 to 4A with radiation only, ideally there is a very good control and hysterectomy is usually not needed, but salvage hysterectomy or exenteration is recommended if there is residual disease which is confirmed after 3 months of treatment, and it is confirmed either with a PET-CT or biopsy, because otherwise hysterectomy or exenteration leads to a significant morbidity. It's a strong recommendation and quality of evidence is high. For patients with stage 1A1 to 1B2, definitive RT is surgery is a preferred treatment, and radiation is a conditional recommendation. Radiation is a conditional recommendation. Now the question 3 was, for patients receiving definitive radiation for cervical cancer, when is it appropriate to deliver IMRT? So we all know that IMRT decreases the volume of bladder, rectum, bowel and bone marrow, volumes of bladder, rectum, bowel and bone marrow. And in fact, it also improves patient-reported GI and GU adverse events, but it does not improve disease-free survival or overall survival. In fact, RTOG 1203 or Times C is the only published phase 3 RCT of three-dimensional conformal radiation versus IMRT in post-op patients. So the advantages were that three prospective randomized trials and one meta-analysis showed decreased acute and late GI and GU toxicity. The advantage with IMRT is that you can boost para-aortic lymph nodes and you can give doses up to 55 to 65 gray. But mind you, target motion assessment is very, very important if you are using IMRT. As you can see in this picture, that if there is a significant bladder in the PTV as seen in this figure, and if you have to cover the uterosacral ligaments, then posterior extension in rectum, there is a posterior extension in rectum happens to cover uterosacral ligaments. And in fact, there is a significant motion of uterus itself because of partial bladder filling. So target motion assessment is a must. So IMRT for definitive RT is a conditional recommendation, while post-op radiation IMRT is a strong recommendation. Now the question number 4 was for patients receiving definitive RT for cervical cancer, when is brachytherapy indicated? So brachytherapy for definitive RT is definitely a must, because brachytherapy improves survival compared with IMRT or SBRT as a boost. And SBRT and or IMRT is not at all a substitute for brachytherapy. It's used only for unsuitable cases. In fact, if you exclude brachytherapy, it has a stronger negative impact than exclusion of chemotherapy. If you are using brachytherapy, 3D based planning leads to a better local control and less toxicity. While for post-operative radiation, they have recommended brachytherapy only if there is a vaginal mucosal margin positive, if parametrial or paravaginal margin is positive, or macroscopic margins are positive. And you may use an intracavitary multi-channel cylinder or interstitial needles if needed. Overall survival is 79.4% versus 71.9% at 3 years. If a center does not have facility for brachytherapy, it is better to refer the patient to higher center. And if brachytherapy is not possible, only then give external beam boost. So brachy for post-op RT is a conditional recommendation, although we have been routinely using brachytherapy for all post-op patients. And for definitive RT, brachytherapy is a strong recommendation in this guideline. Now, the fifth question addressed was for patients receiving definitive radiotherapy, what is the optimal dose, fractionation, scheme, imaging, and technique of delivery of brachytherapy? So we all know that Jack Astro gave us definitions of GTV, high-risk CTV, intermediate risk CTV, and from retro embrace, we know that image-guided brachytherapy improves local control, reduced toxicity, and led to altered pattern of relapse relative to 2D brachytherapy. In fact, with 3D brachytherapy, there are reduced grade 3 to 4 toxicities, and which came down from 22.7% to 2.6% with 3D brachytherapy. With 3D brachytherapy, it came down to 2.6%. But for intraoperative imaging is strongly recommended, and CT may overestimate tumor width than MRI. So use MRI or CT-based planning for volume-based prescription. It's a strong recommendation. If volume-based planning cannot be done, then use 2D-based brachytherapy, which is a strong recommendation. This is a flow chart that they have given for brachytherapy. So basically, EQ-D2 for external beam radiotherapy, if the tumor size is less than 4 centimeters, then try to achieve more than 80 gray to high-risk CTV if you are using a D90 volume-based planning. But if it's an adenocarcinoma histology, poor response to external beam radiotherapy, residual is more than 4 centimeters, and it's a stage 3 disease, try to escalate to up to 85 gray, more than 85 gray. If it's a 2D point A based dose specification, then try to give 80 gray, more than 80 gray to 2D point A dose specification. These are the different brachytherapy regimens which have been given in combination with 45 gray external beam RT. So these are the different dose constraints for rectum, bladder, vagina, and in fact for rectovaginal point, it has been defined as 5 millimeter posterior to vaginal mucosa from the center of the vaginal sources. And if OER constraints cannot be met despite best efforts, then tumor coverage has to be prioritized after careful discussion with the patient. So these were the different points which were addressed for cervical carcinoma. Now, as we all know that a lot of advancements have happened in brain tumors because of molecular classification. So a lot of literature has come up now for molecular characterization of endometrial carcinoma. And since the TCGA first published their data in 2014, so these are various papers which I've combined and would be covering in a few slides. So these are two slides which I have made for they are in a way just for managing endometrial carcinoma, low risk, intermediate risk, or high intermediate risk and high risk. And these are, I will be sharing these slides with all of you. And this is just a slide for management of high risk stage 2, stage 3, and high risk non-endometrioid carcinoma. So these are the various molecular classifications which have come up in various papers. So they basically divide endometrial carcinoma into 4 subtypes. One is pole mutant. This constitutes 6 to 12% of endometrial carcinomas. The pole mutant is usually seen in young age, early stage, high grade endometrioid carcinomas, with patients with low BMI, and they have scattered tumor giant cells and they have a prominent lymphocytic infiltrate. In fact, they are mainly microsatellite stable, but some may have protein loss. And mind you that in spite of pole mutant, 42% may have TP53 mutation, but it's a passenger mutation. So if there is a P53 mutation, it is usually considered as a high risk. But if pole mutation is also present, then even then it has an excellent prognosis. So in these cases, after surgery, RT can be omitted, or in fact, CT may be omitted even for high risk. And because these are they are high grade, immune checkpoint inhibitors are useful for pole mutant. For MSI subclass MMR deficient, they constitute 25 to 30% of the cases. And in fact, reflex testing for MLH1, MSH2, MSH6, and PMS2 should also be done. This is seen in old age. Patients are usually for higher stages, stage 3 and stage 4. They are usually higher grade. They have abundance of tumor infiltrating lymphocytes, and LVSI is seen in 8.9% of cases. So because they have LVSI, so external beam radiotherapy leads to good control. These have intermediate prognosis. CT may be omitted, and immune checkpoint inhibitors are useful. Then if we come to copy number high, these are TP53 mutated. They are high grade and they are usually associated with serous and serous-like carcinomas. 90% they harbor TP53 mutations. In fact, they also show HER2/neu amplification and they also show homologous repair deficiencies. So PARP inhibitors and platinum compounds are useful. They have a poor prognosis. So dose intensification would be needed for these cases with TP53 mutated cases. And there is one more, which is copy number low. They have a low TP53 mutation. They are seen in low to intermediate grade endometrioid. They have a low mutational burden. They have an intermediate prognosis and they show CT, NNB1 and P13K alterations. So dose escalation may be done in these copy number low cases. So these are the 2 molecular classifications. This is given by a transportec molecular classification, and this is the PROMIS molecular classification. So I'll tell you how to proceed. So basically, if there's any new patient with endometrial carcinoma or with serous or clear cell carcinoma, first we should do a pole testing. If pole is mutated, then they are taken as pole mutated. If it is a pole wild type, then do a MMR deficiency testing. If MMR deficiency is present, then they are MMRD deficient. But if MMR proficiency is there, then you check for P53 mutation. If P53 is mutated, then they are taken as copy number high. If it is wild type, then they are taken as no specific molecular they fall into NSMP group. In fact, for uterine carcinosarcomas, also they have a high range of TP53 mutation ranging from 64 to 90%. And in fact, 70 to 80% they resemble serous carcinomas, and only 20 to 33% resemble endometrioid carcinomas. Pole mutation is seen rarely in 3 to 4%, and MSI mutation is seen only in 3 to 20%. So they have a
Yes,
drugable mutation.
thank you,
Yes.
Dr. Indu. In considering the time factor,
So, yeah, this is the last slide.
yeah, sure.
This last slide, I won't go into the next presentation. So this is a proposed model of the integration of molecular classification with pathological features. And this is the chart which they have recommended for management of these patients. So I'm not going into this excellent paper, which was showing that if brachytherapy is not an alternative, then how we can use SBRT or IMRT. So I'm skipping these slides. And this is just one last slide which shows management of carcinoma vulva. That's all I have to say. And thanks, Sayan, for giving me this opportunity. Thank you so much.
Thank you, Dr. Indu.
Thank you.
Thank you. Thank you, madam, for the excellent talk. And now we'll go to our next talk. Next talk is by Dr. Vamshi Krishna. And Dr. Vamshi Krishna is a senior consultant medical oncologist in Apollo Hospital, Hyderabad. And Dr. Vamshi Krishna is also a contributor of this book. I request Dr. Vamshi Krishna for his talk in lung cancer, year in review, immunotherapy, and targeted therapy. Dr. Vamshi Krishna, please.
Sir, please unmute yourself, sir, Dr. Vamshi.
Yeah. Good evening, everyone. It's possible to show my slides. There's no option to screen here. Okay. Sayan?
Yes,
Sayan? Is it?
They are allowing. Yes, you can share your screen. They're allowing you.
Now there seems to be some. Yeah, there seems to be an issue with sharing. It's not allowing me to share. What I'll do is I'll send you the PPT. Can you please share it with the?
No, they are allowing you. They are allowing you. In a second, you will be able to share it. I think they are allowing you.
Okay.
Just try now.
No, there seems to be an issue here. I'll do one thing. I'll send it to you.
Okay.
Instead of. Okay. And in the meantime,
sure.
I know it won't be. I'm sorry for this, but would it be possible for Dr. Moses to present? Then I can just do this.
Yeah, sure.
Sir, can you unmute yourself, sir?
Yeah, Dr. Moses Arun Singh is a senior consultant radiation oncologist at Tata Medical Center, Kolkata, and he will be talking on radiotherapy and combination therapy in cancer lung, year in review for last 1 year's important articles. Dr. Moses, please.
Thank you, Dr. Sayan. Share my screen. Is everyone able to see my screen?
Yes, your screen is visible.
Yes, sir.
Thank you. So for the next 10 minutes, because it's just 10 minutes, I will just be glancing through some 5 abstracts or papers which were presented in the last 1 year, which I found to be interesting. So first up is this trial which is trying to minimize the video. Yes, so there's this trial which looked at a combination of aggressive upfront local radiation in EGFR mutated non-small cell lung cancer patients who were deemed to have oligometastatic disease. So this is a presentation of interim results in the recently concluded ASCO meeting. So this trial randomized patients with 5 or fewer metastases who were naive to any systemic treatment and were going to start on TKI therapy to receive upfront SBRT to a dose of 25 to 40 gray in 5 fractions to all sites of known sites of disease, along with tyrosine kinase inhibitors to just tyrosine kinase inhibitors alone. It was a small study with just about 130 odd patients. So the primary endpoints was progression-free survival with overall survival as the secondary endpoint. So what's the rationale for the study? So the rationale is that anyone who's on a first-line tyrosine kinase inhibitor treatment, the original sites of disease tend to be the common sites of first progression. So if we are able to control that better, then we may be able to improve the outcomes with the TKI treatment. So where is the evidence for this? In previous publications, it's been shown that about 47% progress only at known sites of progression, and among these, 35% of them progressed both at the primary at the other metastatic sites as well, and 48% would progress only at the primary site alone. And in those who continue to have the first-line TKI even after first progression because of clinical benefit, about 74% of them would progress again in the primary site alone at the time of the second progression. So with this background, looking at the results of the study, we can see that incorporation of SBRT definitely leads to improvements in the median progression-free survival and the overall survival. So whenever we add another treatment, the thing that we worry about is increase in toxicities, but it's gladdening to see that this trial did not result in significant worsening of toxicities with the addition of stereotactic radiation. So the limitations of the study are that it is just a small study with just about 130 odd patients. They called 25 gray in 5 fractions as an SBRT dose, but that seems to be a very mild dose for considering that we are dealing with NSCLC. And also, the trial strangely did not allow use of second-line TKIs based on resistance patterns, and also included exon 20 insertion mutations, which have been known to have worse outcomes with TKI management. So basically, this is hypothesis generating, worth testing out in a larger trial and a better design trial with allowance for use of second-line TKIs. So moving on to the second study, it's again a phase 2 study, which looked at dose escalation of twice daily radiotherapy in limited stage small cell lung cancer. These patients were staged with PET CT scan and were planned to receive 4 cycles of platinum etoposide, and were also planned to deliver PCI in those who are responders to chemoradiation. They were randomized to the current standard of care, that is 45 gray in 30 fractions twice daily radiation versus 60 gray in 40 gray fractions of twice daily radiation, with the primary endpoint of 2-year survival and secondary endpoints of toxicity and OS and PS. So again, the rationale for the study is that because of the advances in the radiation techniques, the availability of PET CT staging, the hypothesis is that there will be a safe escalation of radiation dose, resulting in better outcomes. This is a background to the study. So 45 gray in 30 fractions was set as the standard of care way back in 1999 with the use of 2D radiotherapy, elective radiation fields, and also PCI only for complete responders. There was an attempt to overthrow that in 2017 with dose escalation in a conventional once daily fractionation, but unfortunately this trial did not show superiority, which was the primary hypothesis behind the trial, although it used modern techniques of radiation and no elective radiation fields were there, and more than half of them had PET CT as part of the study. So coming to the result of the current study, it is interesting to see that definitely dose escalation has resulted in better 2-year overall survival and median survival, although the response rates were not better with the 60 gray arm. So it would be interesting to find out why the survival is better, although the response rates were not any better with dose escalation. But gladly, the toxicities were not significantly worse with the dose escalation, although neutropenic infections were slightly higher in the once daily arm. So the second line treatments and completion of treatments were similar between the two groups. The one drawback was that the analysis was not by intention to treat. Several patients were left out in both arms, and the standard arm results were inferior to the Convert trial results, which would be the benchmark for outcomes in the modern times. And the future is likely to be with combination of immunotherapy as a maintenance treatment post chemoradiation as well. So any future trial will also have to include that as part of the trial as well. So moving on to the third trial, this is something that we talk about very often nowadays, the augmentation of immunotherapy effect with the incorporation of radiotherapy. So this is a pooled analysis of two randomized trials which have been published earlier, the Pembro RT and another trial from the Indian Anderson Cancer Center. So both these trials included advanced NSCLC patients who were treated with pembrolizumab, regardless of PD-L1 status, and one arm were deemed to receive radiation either in an SBRT dose in the Pembro RT trial, and the MD Anderson trial had either SBRT or non-ablative radiotherapy as part of the treatment. So the endpoints were out of field overall response rates and disease control rates, and the subgroup analysis included the analysis based on different RT groups. So the rationale for the study is that this pooled analysis is that it would help them to validate and explore whether RT improves outcomes in addition to pembrolizumab, and it will be very happy to see that definitely addition of radiation improves the outcomes with pembrolizumab compared to pembrolizumab alone. So the out-of-field overall response was better, and similarly PFS and OS is also better with the incorporation of radiotherapy. Also, the ablative radiotherapy tended to have better outcomes than the non-ablative radiotherapy. And the one thing that we need to be careful about when we incorporate radiation to immunotherapy is immune-related adverse events. Of course, fatigue and pneumonia were more common in the combination group, but that would not be put down to the combination of radiation to the immunotherapy. But there was one patient in the Pembro RT trial which possibly had an immune-related adverse event which was augmented by the SBRT. This was a patient who received radiation to the retroperitoneal lesion and resulted in an nephritis, resulting in discontinuation of treatment. Like in life, there is always need for balance. So we win some and we lose some, and this is one trial where radiation lost, and this was presented in the recently concluded Science Weekend of ESMO 2020, the long-awaited lung art trial, which we debate very often in radiation conferences. So this trial looked at the role of postoperative radiotherapy in pathologically proven N2 disease. So they were randomized to receive either postoperative radiotherapy with 54 gray in 27 to 30 fractions, or no postoperative radiotherapy. Quite a large trial with the primary endpoint of disease-free survival and secondary endpoints of toxicity, patterns of recurrence, and overall survival. What was the rationale behind the study? Ever since the first meta-analysis came out, and which showed that possibly in N0 and N2, there was detrimental effect, and N2 needed further evaluation in randomized trials. This has been a contentious issue with many retrospective and CR databases showing that possibly there is benefit with radiotherapy in N2 disease. But it was still to be tested out in a randomized trial, and this was this effort. So at a median follow-up of 4.8 years, the incorporation of postoperative radiotherapy did not result in a significant improvement in disease-free survival. We can see that although there is a slight increase in the DFS at 3 years, the OS is slightly worse with incorporation of postoperative radiotherapy. And this can be explained by these two next rows, which shows that the event of death as a first DFS event was much higher in the postoperative radiotherapy arm, and this is possibly due to the incidence of significant cardiopulmonary toxicities and the incidence of second cancers in those who receive postoperative radiotherapy. So cardiac toxicity has again turned villain in another lung cancer trial. This is the second trial where possibly cardiotoxicity has definitely been proven to be the significant adverse outcome factor. So this trial was cannot be faulted for using modern radiation techniques, and 90% of them at least have PET-CT staging. One of the good factor was that the outcomes of control arms were better than what the investigators expected previously. So lastly, this was a small poster presentation at the recently concluded ESMO 2020, looking at the role of palliative radiation for someone who has asymptomatic brain metastasis and going on to receive palliative chemotherapy for non-squamous lung cancer. So, but the trial was not completed. It was stopped after accruing about 100 patients, half of what was intended. Due to poor accrual, these patients were randomized to receive either upfront radiotherapy followed by chemo, or chemotherapy followed by radiation, and all of them had MRI brain after every alternate cycle for evaluation. The primary endpoint was PFS, and secondary endpoints were and survival without neurological symptoms and neurological objective response rates. So the rationale was that the role and timing of radiation therapy is not well established in this setting. So the results showed that not much of difference in PFS and OS between the two arms, regardless of whether we give upfront radiotherapy or start off with chemotherapy and give radiotherapy at the time of progression. It doesn't make any difference in those with asymptomatic brain metastasis. So with that, I conclude my talk. Thank you, Dr. Sayan and the publishers for this opportunity.
Thank you, Dr. Moses. Excellent talk, and you covered almost all the important trials. Now we can have Dr. Vamshi Krishna's talk. Dr. Vamshi Krishna, Senior Consultant Medical Oncologist, Apollo Hospital, Hyderabad.
Good evening, everyone, and I'm sorry for that bit of a technical snafu, but I think things are resolved up. So, requesting the slides to be shared.
Sure, Dr. Vamshi. Sure. 1 second.
I will do it.
To present about metastatic non-small cell lung cancer, and this is a field where, to be honest, has been a change compared to what we used to deal with medical oncology, and we were treating out of the scope. Today, metastatic lung cancer has become the final frontier, and like the Star Trek, we are boldly going to now, I am not going to present individual slides, mainly because the presentation squamous and non-squamous, what we are looking at is a personalized treatment. Personalized treatment will depend upon the biomarker analysis. Either we go for a targeted therapy, which is based on the driver mutations, or we go on a biomarker PD-L1 driven immunotherapy paradigm. That's become the overall picture now. So what I do is I will go by step first the driver mutation space, just touch upon the trials which 1 to 2 years. Next slide. Starting off with the EGFR subset of the adenocarcinomas. Now mostly this is the adenocarcinomas only. Next few slides you can just press the button. Now the treatment strategies include going with the first gen TKI followed by a T790M mutation analysis, going with the third generation TKI. Starting with the second generation TKI, starting with the third generation TKI, or else going with the first generation with chemotherapy or first generation with VEGF inhibitor. These are the options that we have in 2020. Next slide. The whole discussion really went on with the IPAS and the earlier trials, which were in the first generation. And then we had two studies of the second generation. The afatinib studies, unfortunately, the Capmatinib study, the Archer 1050, showed that there was a significant benefit of the overall survival of around 7. Next, the study of Archer was stopped by the pharma. Next slide. Now, and the overall survival results which came last year, and this was positive. It showed 38 was 31 months, but was slightly disappointing when you looked at the hazard ratio. Next slide, which was 0.799, just inching close to the unity. So still impressive, no doubt a positive trial, but not the end game, not the knockout punch that some of us are expecting. More unexpected, the subset analysis which showed that in the L858R arm, really this osimertinib did not have an overall survival. Reverse was true for Capmatinib. Next slide. At the same time, we also start seeing these, next slide, of what we were talking about, the VEGF inhibitor and the as well as the chemotherapy. First trial was the NEJ026 and one was the delay. One used erlotinib plus bevacizumab and showed an overall survival of close to 50 months. The other paper was the delay study, which showed a median EFS of around 9.4 months, both of which were superior to osimertinib alone. However, side effects are not consequential and a lot of patients discontinue. Next slide. The next important papers came from our own very own PMH, which did a study of chemotherapy plus geftinib versus geftinib. Some of us were not very willing to accept this protocol, but really hats off the team, Dr. Nita and Dr. Kumar, who brought out this paper and showed an 8-month benefit when you added geftinib plus chemo. This is important for India. A lot of our patients, we can discuss in any number of webinars, but 90% of our patients will never go on to osimertinib and dacomitinib. For that 90% of patients, using this combination is definitely a very good option. Unfortunately, the OS in the study was not really as good as the other studies, but again, that's kind of expected in our own area. The study was also corroborated by the Chinese that combining chemotherapy gave you a better hazard ratio. They found a PFS of around 20.9 and an OS of more than 50 months. So next slide. What would be my take on the treatment of EGFR positive metastatic NSCLC? So I would go with number one, for those who are affordable without any issues, Del-19, osimertinib is the first choice. L858R, either osimertinib, still I would be okay with, or dacomitinib because that is showing an OS benefit. In case patients are unaffordable, go with the geftinib plus chemotherapy combination if tolerated. I would definitely not go with the geftinib alone at this point based on the results. Afatinib remains an option, especially with the generics. But again, if you don't use it, there is nothing wrong with it. Performance status is important. If performance status 2, I would still consider only oral TKIs. So that's about the EGFR status. Next slide. The next important subset is the ALK. Now, ALK, we had the ALEX study, which showed a really good PFS for the ALK positive with alectinib of 25 months. Now, this continued in this year's paper, which had a phase 3 updated data of the overall survival, and that continued to show that there were with a 5-year overall survival rate of 45%. Remember, we are talking of stage 4 cancer with a 45% 5-year survival. It's pretty unheard of in an NSCLC, and for that matter, for most stage 4 cancers. Next slide. The real new, I would say, development has been this study, which was presented in this ESMO, the CROWN study, which looked at lorlatinib versus crizotinib in the first line, and again, showing a fantastic hazard ratio of around 0.28. For a PFS advantage itself really makes lorlatinib come out in the first line. It's already approved in the second line, and it is available in India. So ALK positive lung cancer is really a space where we are talking of 5-year survivals, where we are talking of longer survivals. Next slide. Continuing this whole trend of the driver mutation driven, The BRAF paper came last year. Again, DABRAFENIB, TRAMETINIB is the combination which we are using. It shows that it is more effective in monotherapy. It is effective in both previously treated patients as well as untreated patients. Numbers seem small, but look at the ORR from 63 and 64%, PFS of close to 10 months. So this is again become the standard of care. You have a BRAF mutation, you would use this combination, whether in the first line or the second line. This has come into the treatment paradigm. Next slide. Along with this driver, we also have the newer things, the Capmatinib, which has come around, which 14 skip mutation. So Capmatinib is again, I have put it here because it is kind of available through a compassionate access, and I guess Novartis will be bringing it soon to India. There was another drug known as Tepotinib, which is also coming in a good way. We don't have access to it, so I'll just stick to Capmatinib. Next slide. So aside from this, the Capmatinib efficacy was seen with a overall response rate of around 68%, a PFS of around 9. Capmatinib is definitely the drug to go. Exon 14 can be initial mutation or a resistance mutation. Next slide. Along with this, we have the whole gamut of the RET positive fusion inhibitors. Selpercapitanib has been approved. Results are impressive, around 9 months PFS, not as much as probably an EGFR or something, but still, this is an option for us. There's another drug which has also come out, Lurbectinib. I'm not sure how to pronounce that name. It's a little difficult to pronounce, but we are having new RET inhibitors as well. Next slide. And of course, the whole NTRK pathway is active. Larotrectinib is one of the first drugs. Entrectinib has come in. None of these available for us. 0.2 to 0.5% mutations of NTRK, but when you get it, these drugs seem to work very well. So that's about the mutation-driven metastatic NSCLC. Next slide. Next came the whole bunch of the immunotherapy trials. Now, we usually stratify it as PD-L1 more than 50%, less than 50%. We have the keynote studies 024, 042, 189, and 427. These are the landmark papers from pembrolizumab. For Atezo, the landmark positive papers were the IM power 150, 130, and 110. 131 and 132 have both just been presented in the ESMO virtual as well as the ASCO, and somehow these papers have been kind of. For nivolumab, in a negative trial of Checkmate 026, durvalumab, negative trial of Mystic, all these are first line. Next slide. So when we get a patient of adenocarcinoma or squamous cell carcinoma, we need to go for the PD-L1 testing based on the keynote 02 and IM power 110. All these are showing a PFS advantage, and more importantly, they are showing an overall survival advantage. Now, the keynote 042 and the 110 are showing an OS around 20 months, the hazard ratio 0.7, 0.6, both pretty impressive. Then you have the combination, that is the Pembro plus combination, the keynote 189, the keynote 427, IM power 130 and 150. All these are again positive studies except the 130, which did not show positive overall survival. Overall, where do I look at it? Definitely, if it is less than 50%, we would go with a Pembro plus chemo. Atezo chemo, probably not as much. The ABCP protocol, yes, that can be used, but the other trial of only the chemotherapy plus Atezo, I am somehow not very convinced of it. Next slide. We have to remember that there are some dishonorable mentions when we talk to immunotherapy. Checkmate 026 was a failure for nivolumab in the first line, despite looking at PD-L1 of 50%. Mystic was a pretty big failure, despite using durvalumab and tremelimumab combination. IM power 131, again using Atezo, Carb, Nab-Paclitaxel versus Nab-Paclitaxel, no benefit. IM power 132, PFS advantage, however, OS, no benefit. I have to mention the Checkmate 227, the Nivo EP arm here, which did show a benefit, but again, we are having a lot of issues with that study. We had to look at first TMB, now they're saying PD-L1, so it's kind of not still in the first line, and I think that's going to really be in the later lines. So that's about the immunotherapy in metastatic NSCLC. Next slide. So when the immunotherapy, why are we excited? And this paper, which was presented in this ESMO virtual, can somehow give you an idea. A keynote 5-year OS advantage was shown to be around 30%. So driver mutation, I told you with ALK, we are getting 45%. Here with the immunotherapy driven, you are having a 5-year overall survival close to 30%, which again was pretty much unheard of. The last slide, which I have really not put up, I thought Dr. Moses covered it, was the Caspian study, which looked at durvalumab following CTRT, again a positive study. And that has kind of become the standard of care, though the overall survival really hasn't come into as much picture as we would have liked. So that's about disease to treat, but again, a fascinating disease and something which really has shown us the power of personalized medicine, looking for treatments, looking for drugs, and that might you, Sayan.
Thank you, Dr. Vamsi. As usual, fantastic presentation and summarize almost all the important trials. And it's very encouraging to see that so many MIFs and MAFs have come and so many immunotherapy trials are also going on. So now, let me share my screen. So now I'm very glad to announce that the publishers of this famous book, the Bethesda Handbook of Clinical Oncology, Wolters Kluwer. This book, I think all of us already have read at some point of time during our residency or post-residency, and it's a must companion in our clinics also for ready reference. So this book, they have decided to publish one South Asian edition. For the first time, they are doing this, and they had requested us to edit this book, and I'm very glad to announce that we have all Indian authors. We have edited this book, and this book is now available in the market and in online platforms, the Bethesda Handbook of Clinical Oncology South Asian edition. So first and foremost, what are the strong points of this book? I believe that the strongest point is the contributors. So we have excellent contributors to edit this book, and contributors are from different parts of India, and they are all very, very famous oncologists in their own field. So we have Dr. Moses Arun Singh as contributor from Tata Medical Center, Kolkata, Dr. Geeta Babu from RCC Trivandrum, Dr. Sushavan Banerjee from Medanta, the Medicity, Gurgaon, Dr. Indu Bansal from Narayana Super Specialty Hospital, Gurgaon, Dr. Rimpa Bosu Achari from Tata Medical Center, Kolkata, Dr. Cecil Kanikal from RCC Trivandrum, Dr. Siddharth Chakraborty from Apollo, Hyderabad, Dr. Sayan Das from Narayana Super Specialty Hospital, Howrah, Dr. Tushti Ganguly from Kolkata, she is a senior hematologist, Dr. Joajiv Ghosh from Tata Medical Center, Kolkata, Dr. Bhamshi Krishna from Apollo Hospital, Hyderabad, Dr. Indranil Malik, senior consultant, Tata Medical Center, Kolkata, Dr. Rima Pathak, Associate Professor, Tata Memorial Hospital, Mumbai, Dr. Tanvir Shahid, Senior Consultant, Apollo Hospital, Kolkata, and myself, Dr. Sayan Paul from Apollo Hospital, Hyderabad. All of us have worked almost 6 months to edit the book and to make it more relevant for the residents and the practitioners of this part of the world, the Southeast Asia and mainly India. So what are the key points of this book? So first of all, the last edition was in 2018. So we have updated and edited all the chapters. Till May 2020, all the new guidelines, new articles, new evidences, all have been incorporated in each chapter. And from India and this part of Asia, South Asia, whatever data and evidences have been published and we found relevant for each chapter, we have included that in the chapter. So that can be guidelines also, that can be published articles also. Like there are many Indian guidelines also, which we refer in our day-to-day practice, but it's not included in any book. We have included that. And for to make it more apprehensible and more easy to understand, at the end of each chapter, one management flow chart we have added. So in each chapter, we will find the management flow chart. So if a disease for a particular site, for a particular type of disease, what should be the diagnostic test and how should we go? What should be the sequence for diagnostic test and how to manage? If it is a multimodality management, how to sequence the management, what modality to be used and how it should be used and how the patient should be followed up. We made a flow chart for each and every site. So that I feel will be very, very beneficial for whoever reads this book. And more emphasis we have given for the tumor, common type of tumors that we encounter day to day in our clinics. Because in this part of world, cancer of head and neck, cancer cervix or breast, these are common cancers. So we don't see too much skin cancers. And in West, it is not that much because they don't have that much of head and neck cancer or cervix cancer. So that is actually the main reason of writing this book, because their pattern of practice and our pattern of practice, there is a little bit of difference. The cases they see is mainly early stage cancers, and we see mostly advanced stages cancer. So we needed one book, or we needed one modification of one book which includes all these things that we frequently encounter in our day-to-day practice. And there was a chapter on basic radiation oncology and medical oncology that has been thoroughly revised. So we have added many key points in radiation oncology and medical oncology. And more relevant information for cancer surgery also added in each chapter. Like for each site, what type of surgery is to be done, what are the other type of surgery available, and 1 or 2 lines about those surgery. I feel that all the residents, like medical oncology, surgical oncology, radiation oncology, and all the practitioners, all will be benefited if they read this book. So I request each and every one of you to collect your own copy. It's not costly. It is available in Amazon, Flipkart, and Google, and all kinds of online platforms and medical bookstores. And it's only around 1,000 rupees. So it's not even costly. So I request all of you to collect your own copy. It's not because we are going to earn anything from this. It is because we want to continue this. Because if you people appreciate this book, you people like this book, we will get another chance to edit this book, and maybe we'll do it better every time. So I request all of you to please collect your copy, and I request our publishers, Mr. Sarvanan from Wolters Kluwer, to say a few words on this book.
Yes, thank you, Dr. Sayan Paul, for explaining us to the special salient features of this title. This book is very important book for us as a publisher in clinical oncology segment. Dr. Sayan Paul is really a fantastic author. In spite of his very busy schedule, he helped us to achieve the book to publish on time as planned. Thank you so much, sir. And this book has very good salient features. Like Dr. Sayan Paul quoted earlier, it has data on evidences from India and South Asia. That is the major point in this book. And out of 46 chapters, we have edited almost 30 chapters and added management flowchart at the end of each chapter, which gives us an easy understanding of the title. So chapters of basic of radiation oncology and medical oncology have been revised. Additional and relevant information on cancer surgery has been added in each chapter. So thank you so much, Dr. Sayan Paul, for this fantastic job, sir.
Thank you, Mr. Sarvanan. I request Dr. Tanvir Shahid to say a few words about this book. He is one of the contributors and he was involved from the beginning. Dr. Tanvir, please say a few words.
Yeah, am I audible?
Yes, sir. Yes, sir.
Good evening, all of you. At the onset, I'd like to thank the publishers to begin with, Sayan Paul, for giving this opportunity. In fact, it's my privilege that I was a part of this endeavor, and I really take it as a pride that I got an opportunity to edit this book. 3 chapters particularly, I was very much keenly interested in doing the basics of radiation oncology as one of the chapters. And I really am very excited that not only our younger colleagues, but even we as an oncologist will benefit by reading it and by sharing with everyone. So thank you. Thanks a lot, the publishers and Sayan and everybody who has contributed. And we are here to really be taking it as a pride that we did something meaningful, and we look more of this kind of assignments in future. Thank you so much.
Thank you, Dr. Tanvir. Thank you for these kind words. I request Dr. Moses to say a few words about this book. He is also one of the contributors and he has edited many chapters.
Thank you, Dr. Sandra. It was a pleasure to be part of this project. So early on, when the lockdown was starting up and everyone was relaxing, so Sayanda was sitting in his home and scheming as to how to put all of us to hard work. So as all of us know, most of the oncology books that are available in the market are mostly oriented towards Western practices, just as it was mentioned just now. So Sayanda has rightly come out with this project to come out with an Asian edition of this clinical oncology handbook with specific emphasis on Indian data and practices, and the Asian data and practices. So it was really an honor to be part of this project, and it was a learning experience also for me to be working on this. Shanda was really a hard taskmaster. He put us, all the contributors, into a WhatsApp group and kept repeatedly guilting us with repeated reminders for meeting the deadlines. And I must say the end result is definitely a wonderful handbook, which I'm sure would be very useful for all the oncology trainees and practitioners. And the support and need for such a book is very apparent and palpable from the amount of response that it has got on the Amazon platform and other online platforms as well. So hats off to Dr. Sayan and the publishers for this endeavor. Thank you.
Thank you, Dr. Moses, for the kind words. I know that it was a very difficult time during this COVID pandemic, and I made everyone's life very difficult. So I was very strict, and I was like, I mean, I know that you people are like, my post are like was so scaring for you. But anyway, you people have worked so hard. Like, I'm very, very thankful that I'm a part of this team. And I also, during this process, learned a lot. So we have Dr. Sayan Das, who has also edited many chapters. Dr. Sayan Das, will you say a few words about the book?
Yeah, thank you. I would first of all, I would like to thank you and the publishers for giving us this opportunity. And as my previous speakers have already mentioned, yeah, I am honored to be part of this venture. And truly, it was great working with this team with so much guidance available. You have beautifully summarized the good points about this book. What I would like to again emphasize is what I believe would be really useful for the residents mostly will be the treatment algorithms that are there at the end of each and every chapter. And as previously mentioned, that yeah, the textbooks do not commonly mention Indian data. We have tried to put in as much Indian data as possible. And I'm looking forward to the reviews that come on the online platforms where the book is available, because we are really interested to know the feedback so that we can work and give you a better result next time when we probably bring out the next edition. Thank you, Sayanda, and thank you thanks to the publishers.
Thank you very much, and you have mentioned a very important point. Yes, I request everyone to review the book. We should get some feedback so that we can improve next time. So because we don't have much time, we'll move on to the next talk. Next talk is by Dr. Indranil Malik, who is Senior Consultant Radiation Oncologist, Tata Medical Center, Kolkata, and he will be talking on prostate cancer.
Hello, Dr. Indranil, are you available?
Please play it, Mr. Ravi.
Who's doing it? Give me a sec.
Yes, yes. You play it from your side. Is it okay? Can you do it from your side? Yes. Voice is not visible. Or is audible. No, the voice is not good. Can you take it?
So now are you able to hear it?
No, can't hear.
Just hold on.
Yeah. Or else we can do one thing. We can go to the next talk.
Yeah, please do it, sir. Please do it. I request you to do it. Go ahead with the next topic.
Yes, yes. So next is Dr. Cecil Canical. He will be talking on head and neck cancers, and he is senior senior professor in Regional Cancer Center, Trivandrum, Kerala. So he will be talking on head and neck cancers.
Can you permit to share the slide? Can you share the screen? Can you hear me?
Yes, yes. Mr. Ravi, please.
We hear
please
you. Yes.
yeah.
Yeah. Thank you. Yes. Can you see my slide now?
Yes, sir. Yes, sir.
Oh,
Yes, sir. We can.
okay.
Yes,
Thank you very much. Okay, I will take 10 minutes to present 5 abstracts if possible in head and neck. I'll be discussing the major phase 3 randomized trials published in last year in head and neck oncology. 3 abstracts, 3 publications from carcinoma nasopharynx, 2 publications from HPV positive carcinoma oropharynx, and 1 from the locally advanced head and neck cancer, and if time permits, 1 from immunotherapy in recurrent or metastatic head and neck squamous cell carcinoma. So if you look into the 3 publications that published in 2019 regarding the induction chemotherapy in carcinoma nasopharynx, we all know that the business of chemoradiation in carcinoma nasopharynx started with the publication of the intergroup trial, which published in JCO in 1998. That was a phase 3 randomized trial addressing the role of concurrent chemo followed by adjuvant chemotherapy versus radiotherapy alone. And this showed that there is an improvement, 3-year improvement in progression-free survival and overall survival compared to radiotherapy alone. And this became the standard of the locally advanced carcinoma nasopharynx. From there was a 2 publication came in 2005 in the same edition in JCO, one from Hong Kong group and other from Singapore, which the trial was contradictory. One trial was positive, other was negative. The Singapore paper was positive and the Hong Kong paper was negative. So it's 2 meta-analysis which was published at that time in 2004 in JCO and 2006 in Red Journal. Both showed that the benefit of chemotherapy along with radiation in nasopharynx is mainly in the concurrent fashion, and the adjuvant and the neoadjuvant was not of much benefit. The biggest question was that what is the role of adjuvant chemotherapy along with concurrent chemoradiation in advanced disease? And this was addressed in a paper which published in Lancet Oncology in 2012 by Chen et al., which compared concurrent chemoradiation versus the concurrent chemo followed by adjuvant chemotherapy. And it have shown that in the initial publication came in Lancet Oncology in 2012 and updated the same article, same paper in European Journal of Cancer in 2017, have shown that there is no benefit by adding adjuvant chemotherapy in addition to concurrent chemoradiation. So then the concurrent chemoradiation became the standard. Now, what is the role of incorporating neoadjuvant chemotherapy along with concurrent chemoradiation? That was one of the approaches. There are 6 phase 3 randomized trials addressing this issue, and 3 were published in last year in 2019, and 2 of them was an update and 1 was a publication, first time published. The first paper, that was a phase 3 randomized trial addressing the one is the concurrent chemoradiation alone or concurrent chemoradiation the induction chemo followed by concurrent chemoradiation. 2 cycles of induction chemotherapy, cisplatin plus 5-fluorouracil, was given prior to the standard concurrent chemoradiation for stage 3 and stage 4A carcinoma nasopharynx. T3, N0, N1 patients were excluded. IMRT was not mandatory. And the primary endpoint of this clinical trial was disease-free survival and distant metastasis-free survival. And the initial publication came in European Journal of Cancer in 2017 with 3-year efficacy results and updated in 2019 with long-term follow-up. In the median follow-up of 82.6 months, the data was published in European Journal of Cancer in 2019, have shown that all the parameters, disease-free survival, distant metastasis-free survival, and overall survival were better in patients who received 2 cycles of induction chemotherapy prior to concurrent chemoradiation compared to concurrent chemoradiation alone. And there was no benefit in terms of local regional failure-free survival. This was the first paper. Second paper was the stage 3 and stage 4 carcinoma nasopharynx patients were randomized either to give 3 cycles of TPF, that was a light TPF, followed by concurrent chemoradiation or concurrent chemoradiation alone. And that those was not the standard TPF which was used in the TAX 3-3 or 3-4 clinical trial. This was a modified TPF. This was called the light TPF, 60, 60, and 600 milligram per meter square. And this was the 3 cycles of induction followed by chemoradiation or chemoradiation alone. And the primary endpoint was failure-free survival. Around 480 patients were randomized to 2 arms, and IMRT was mandatory, and node-negative advanced disease like T3 and T4 patients were not included in the clinical trial. And initially, the paper was published in 2016 in Lancet Oncology and was updated in International Journal of Cancer, that is the official journal of the UICC in 2019. And which have shown that in 2016 publication, the toxicity was higher in patients who received induction chemotherapy prior to the chemoradiation. This was 18, grade 4 toxicity was 18% in patients who received induction, and it was 1% in patients who received chemoradiation alone. And if you look into the efficacy results, which was updated in the International Journal of Cancer in 2019, with a median follow-up of 71.5 months, which have shown that all the parameters, the failure-free survival, overall survival, distant metastasis-free survival, or local regional failure-free survival, all were better in patients who received induction chemotherapy prior to the standard chemoradiation. The third paper, which was presented in ASCO annual meeting in 2019, was published in NEJM in 2019. And this was again a stage 3 and stage 4 patients were randomized either to give 3 cycles of induction chemotherapy with cisgem, followed by chemoradiation or the standard concurrent chemoradiation. And why they have chosen cisgem as the induction chemotherapy regime was based on the data which was published in Lancet Oncology in 2015, comparing cisgem versus cisplatin 5-fluorouracil in recurrent or metastatic nasopharynx. It has shown that the primary endpoint, the progression-free survival or overall survival, were better in patients who received cisgem compared to cisplatin 5-fluorouracil with a better toxicity profile. And that's why they used cisplatin gemcitabine as the induction chemo regime. And when the data was presented in the ASCO annual meeting in 2019, later published in NEJM a few months after that, which have shown that the toxicity was little more toxic in those patients who received 3 cycles of cisgem. And this was a grade 3 or grade 4 toxicity, 20% increase in grade 3 or grade 4 toxicity in patients who received cisgem as induction chemotherapy, followed by chemoradiation versus the chemoradiation alone. And if you look into the primary endpoint, which was relapse-free survival, the second was the overall survival. These were all better in patients who received induction chemotherapy. There was a 4.3% increase in absolute improvement in 3-year overall survival in patients who received induction chemotherapy compared to concurrent chemoradiation alone, at a 20% increase in grade 3 or grade 4 toxicity. And there was a reduction in distant metastasis also, but there was no difference in local regional failure-free survival. So if you look into the 3 clinical trials which addressing the role of induction chemotherapy in carcinoma nasopharynx, all the 3 clinical trials have shown that there is an improvement in overall survival. But it does not mean that all the clinical trials were positive. And there was a publication came in 2015 in Red Journal from the Singapore group, which have shown that there is no benefit by adding induction chemotherapy compared to concurrent chemoradiation. There was an attempt from the URTC group, the GOTA group, which was published in Annals of Oncology in 2018. The trial was prematurely closed due to poor patient accrual, but there was an improvement in disease-free survival, and there was an trend towards improvement in overall survival, but this was not statistically significant. So, and another trial, again, the Taiwanese group, the Taiwan Cooperative Oncology Group, this was also published in 2018, have shown there is conflicting results. So never think that all the clinical trials were positive for induction chemotherapy in CA nasopharynx. There are two meta-analyses, one published in 2018, other published in 2019, have shown that there is a benefit in terms of overall survival, progression-free survival, but there were also pitfalls. It was not an individual patient data meta-analysis. So the conclusion is that in patients who have T3, T4, N2, and N3 disease, T4, T3, N2, and N3 disease, there is an emerging role for induction chemotherapy in carcinoma nasopharynx. The next two paper again came in Lancet in 2019, which was one was the RTOG 1016 clinical trial, and another from the UK group, that is the de-escalate. And the RTOG 1016 clinical trial was presented in ASTRO annual meeting in 2018 and was published online towards the end of 2018, but this is officially published in the first month, that is in January 2019 in Lancet. They came in both same edition, that is a de-escalate and the NRT clinical trial RTOG 1016. There is a slight difference in the inclusion criteria between these two. If you look into the de-escalate trial, this includes only low-risk patients, whereas the RTOG 1016 included low-risk and intermediate-risk patients. The number of patients were less in the de-escalate, number of patients were more in the RTOG 1016. The primary endpoint of the de-escalate trial was toxicity, but the overall survival was the primary endpoint in the RTOG 1016. Both trials used the IMRT. The main aim of this trial was to know, can we replace cetuximab with cisplatin in locally advanced P16 positive CA oropharynx? That was the conclusion. That was the hypothesis. And this is mainly based on the subgroup analysis of the Bonner trial, which was published in NEGM. So it was found that it was not a planned subset analysis in Bonner trial, but it was found that those patients who had oropharyngeal primary, males, patients with performance status 1, patients who received altered fraction radiotherapy, and patients who had P16 positive benefited more from patients who received cetuximab. Whether this can be replicated in a phase 3 fashion in P16 positive patients. And both trials used the same regime, that is 70 green 35 fractions of radiotherapy. Cisplatin was 100 milligram per meter square given in day 1, day 22, and day 43. Cetuximab was the Bonner trial design, same, the loading dose of 400 milligram per meter square, followed by weekly 250 milligram per meter square till the completion of radiotherapy. And the 348 patients were included in the UK trial, de-escalate trial, which included only low-risk patients. The primary endpoint of this was the toxicity, but there was no difference in toxicity between the two arms. And if you look into the results, the 2-year overall survival and the recurrence, the 2-year overall survival was better in patients who received cisplatin compared to cetuximab. 2-year overall survival was 97.5% versus 89.4% in patients who received cetuximab. The 2-year recurrence, the recurrence were also less in patients who received cisplatin compared to cetuximab, and the median follow-up is 22 months. And coming to the RTOG 1016, the primary endpoint was overall survival. Around 987 patients were randomized either to receive cisplatin plus radiotherapy, IMRT, or the cetuximab plus radiotherapy. And this is a non-inferiority design at 1.45. When there was a difference in toxicity profile, and you can see that the mucositis, dermatitis, and rash were more. I will skip. I will finish after this. Okay, thank you for the reminder. The oral cavity, the dermatitis, and the rash were more in patients who received the cetuximab, but the hematological autotoxicity and the nephrotoxicity were more in patients who received cisplatin. And at a median follow-up of 44.5 months, it was found that the 5-year overall survival and 5-year progression-free survival were better in patients who received cisplatin compared to cetuximab. And if you indirectly compare between these two trials, the low risk in intermediate risk patients were included in the RTOG 1016. The de-escalate used only low risk patients. Primary endpoint was overall survival. The long-term follow-up is with RTOG 1016. Number of patients were more. Difference in toxicity profile. And the overall survival were better with cisplatin plus radiotherapy compared to cetuximab plus radiotherapy. So this again, and there was another trial by the Australian group, the TR, I forgot the number, TR I think 005. this is an ongoing phase 3 trial evaluating the role of the same regime, and this is underway. We are awaiting the maybe have initial results maybe within 1 or 2 years. So as of now, we are not tuned to de-escalate, means we are not in a fashion to replace cetuximab plus with cetuximab cisplatin in P16 positive CA oropharynx. I think I will stop here because of the time constraint. Thank you very much, the publishers as well as Dr. Sayan for giving me this opportunity. Thank you.
Thank you, sir. Very nicely summarized, and all the head and neck trials. Now, Dr. Indranil could not came live today. Was not present today because he is traveling. So he has sent his video. I'll play the video. I think there is some technical problem. I could not share it. Let me try again. Just a minute. Give me a minute. Is it visible?
No, sir, not yet.
Let me try once again. Otherwise, we'll go to Dr. Tanvi's talk. So let us go to Dr. Tanvi's talk. In the meantime, I will try to manage this technical thing. So now I invite Dr. Tanvi Shahid, who is Senior Consultant Radiation Oncologist in Apollo Hospital, Kolkata, and he will be talking on CNS tumors. Here in review, CNS tumors.
Is my screen visible?
Yes, sir.
Yes, sir.
Okay, fine. So a very warm good evening to all of you. At the onset, I'd like to thank Dr. Sayan and the publishers for giving this opportunity. I'll try to keep it simple. I have just tried to compile 5 abstracts which I felt that it might be useful. I tried to keep it simple. And these are the trials which I'm going to speak on today. The first trial, which was eagerly awaited, was hippocampal avoidance whole brain RT along with memantine, that is phase 3 trial of NRG CC001. This trial was basically, it was based on the background of RTOG 933 by Vinay Gondai, where hippocampal avoidance was done using IMRT to preserve cognition. The trial design was pretty simple. 3 years of accrual period of nearly 500 plus patients randomized into 2 arms. Hippocampal avoidance, whole brain RT plus memantine, along the other arm was whole brain RT plus memantine, evenly distributed in the terms of number. Evaluation was done by imaging, which was MRI, along with batteries of tests. And important thing was quality of life and symptom burdens were also as one of the endpoints, which is very important. The primary endpoint was time to cognition, function failure, and the secondary endpoint was overall survival, progression-free survival, toxicities, and patient-reported outcome. Evaluation was done at 2 months, 4 months, 6 months, and 12 months. What was very important to know that to see that hippocampal avoidance whole brain with memantine, it had a risk of cognitive failure in significantly low in terms of executive functions, learning, and memory. And in the terms of quality of life, also the hippocampal avoidance with memantine, it did better in the terms of fatigue, memory, communications, and other cognitive symptoms. But the important point to mention over here is that it did not differ significantly in the terms of overall survival, intracranial control, and the toxicity part. So to conclude this trial, hippocampal avoidance whole brain with memantine, it preserves cognitive functions and patient-reported outcome measures. That's important. However, there is no difference in the intracranial progression-free survival or overall survival. And it should be considered as a standard of care for the patients with good performance status and who do not have metastasis in the hippocampal avoidance region. The second paper, which all of us should be proud of, it's from Tata Memorial by Jayant Shastri et al. It is again based on hippocampus. It is a hippocampal avoidance radiotherapy, and this was based on the dose constraint for long-term neurocognitive outcomes, and it was a mature data from a prospective trial which was done before. The trial which was on which this study was conducted was an old trial, that is SCRT trial, where the patients, younger patients, were treated with conformal RT, and they were benign and low-grade intracranial neoplasm, and who haven't taken any radiation before. The dose was 54/30, and it was retrospectively, the hippocampal contouring was done in these patients. 48 patients were taken into account, and the contouring was done on the standard RTOG 933 guideline. And there was no effort to hippocampal sparing because the patient had already been treated, and the hippocampal contouring was done on a retrospective basis. And the neurocognitive assessment was FSIQ, that is full scale intelligence quotient, the verbal quotient, and the performance quotient. Important thing was what was noted that if there was a more than 10% drop from the baseline in any quotients, it will be considered as a clinically significant, and the hippocampus dose in the terms of maximum, minimum, or mean dose was taken into account. We'll be really not bothered about the control because it's a retrospective analysis, but still the control was excellent because these were low-grade tumors. On a univariate analysis, what was very interesting to note that there is statistically significance for as far as the full-scale intelligence quotient is concerned, specifically in relation to the left hippocampal dose. That is very important, that FSIQ was related to the low left hippocampal dose. On a multivariate analysis, again, the decline in FSIQ at 5 years was related to the younger age, that if the patient's age were less than 13, the decline was more. And again, the left hippocampal dose that was significant. The patients of craniopharyngioma, again, they had a greater decline in FSIQ. More than 10% decline was seen in verbal quotient if the patients were of younger age, and in performance quotients if the left hippocampus dose was more than 25 grade. So the conclusion of this trial was that conformal avoidance of hippocampus with modern radiation technique can improve your neurocognitive functions in the terms of intelligence quotient and also can improve quality of life. And it can be considered readily for the low-grade gliomas and benign intracranial tumors because these patients will be long-term survivors. My third study is basically a Spanish trial, that is Gynae 1401. Again, a simple trial, 6 cycles of adjuvant temozolomide compared with 12 cycles, that is extended cycles. And it was again, background was based on the landmark trial by Rogers 2 published in NAGM, which we all are aware about. And the hypothesis that if temozolomide can be extended beyond 6 cycles, can the outcome be improved? Treatment standard, GBM, followed by surgery, standard concurrent chemoradiation, followed by 6 cycles of adjuvant temozolomide. So till here, everything is standard. After that, patients were assessed, and if there was no progression, it was randomized in 2 arms. First randomization, just observation, that is control arm, and the experimental arm, it went ahead and received another 6 cycles of adjuvant temozolomide. I must accept that the patients' number were low. It was around 80 odd patients. The primary endpoint was 6-month progression-free survival difference, and secondary endpoint was PFS, OS, and safety. What was disheartening to see that it really did not make any difference in all the parameters as far as 6 months and 12 months were concerned. Even another important point is even in MGMT methylated group, it did not make a difference of giving extended temozolomide for 12 cycles. In return, what we got added toxicity by giving an extended temozolomide in the terms of thrombocytopenia and other toxicities, which has which was again it is expected. So the conclusion of this trial was that there is no apparent benefit of continuing temozolomide treatment beyond sex cycle. My fourth study is again already a published study, that is RTOG 424, where temozolomide was given in the high risk low grade glioma, and this update was published in Red Journal this year. And previously it was published almost 6 years back, RTOG 424, and there was a survival advantage in the high risk low grade glioma. And this time the long term outcomes of RTOG 424 was published. Standard high risk low grade randomized into radiation alone with radiation plus temozolomide. A primary endpoint is robust overall survival, and secondary endpoint is PFS. At 5 years and 10 years, the overall survival is again pretty good by continuing by giving temozolomide in high risk low grade, along with progression-free survival, again very important. In a subset analysis, what was interesting to see that the female sex and MGMT methylation was again statistically significant in the terms of overall survival and progression-free survival. And the conclusion was again that high-risk, low-grade gliomas, there is improvement in OS and PFS by giving radiation along with temozolomide with an acceptable toxicity. And my last study, and really this study is very close to my heart, ACNS 121, and this study has taught a lot of things. This is published by Thomas Merchant. Everyone knows how much work he has done in pediatric CNS from St. Jude's, and this was basically a conformal radiation therapy for pediatric ependymomas, chemotherapies for incomplete resected ependymomas, and observation for completely. Basically, there are 3 sets of patients who have been dealt in this study. I'll try to make it simplify. There was four different groups, 1, 2, 3, and 4. The first group in which the gross tumor resection was done, that is GTR1, it is called as. That means after surgery, there is no residual tumor either in imaging or even under microscope. And if it is a WHO grade 2 and supratentorial, this patient will be observed and no further treatment will be given. The worst is the subtotal resection, where more than 0.5 centimeters the tumor has been left behind. That means the subtotal resection has been done. Whatever 2 or 3 grade and whichever site, whether supratentorial or infratentorial, these patients will be receiving chemotherapy first. Try to downstage, if possible, go for second surgery and then radiation. So basically, these are the bad prognostic group. The third and fourth are again something interesting, because the near total resection means you have taken out the tumor, but less than 0.5 centimeters of tumor is left behind. And GTR2 means that you have taken out the tumor completely, nothing was seen in imaging, but on microscopic something can be seen. This is different from GTR1, because in GTR1 nothing can be seen in imaging as well as microscopic, but in GR2 nothing can be seen in imaging, but microscopically something can be seen. WHO grade 2 and 3, whatever site, whether supra or infra, radiation will be given. And the last, that is group 4, GTR1, that means everything has been taken out, nothing visible either microscopically or on imaging. And if it is supratentorial 3, because if it had been 2, then nothing would have been done, but it's supratentorial grade 3 or infratentorial 2 and 3, radiation therapy will be given. So if we see the stratum wise, the group 2, where subtotal resection was done, that means significant tumor was left behind, it did badly. The grade 1 was the best grade because entire tumor has been removed, and at the low grade supratentorial, so these are again they did better. And what was important in grade 3 and 4, that where radiation was given on the post-operatively after surgery, even something was left behind, again it did better. So best prognostic group is definitely 1. Supratentorial is again something it is good, and grade 2 only, not the grade 2, not the grade 3. And if you have taken the entire tumor and nothing has been left behind, these will do better. Again, my last slide is again from ACNS 121. This was something very important because it was against the notion, because supratentorial, if there is a RELA fusion, we generally expect that they'll be doing bad. But in ACNS 121, they did not find any kind of a prognostic difference between the RELA fusion or the YAP1 fusion. That was something very interesting to note, because we expected that RELA will do bad, but that was not there. Similarly, for the infratentorial, there are 2 kind of mutation, that is PFA and PFB. PFA, we usually expect that PFA will do bad and PFB variety will do good. But in this particular study, it also showed that it's not only the PFA what is important, but if PFA with 1Q gain will do a bad, and if PFB what we expect that it will do good, it's not like that. If PFB with 13Q loss, again will have a poor outcome. So it went one step ahead and tried to clear that the notions what we have is not exactly, and something new parameters have come. Yeah, and if you really summarize this ACNS 1:1, this is first study to observe patients who have undergone a complete resection that no further treatment can be given. First study where the subtotal resection has been done, chemotherapy and second surgery can be done. Again, it is the first study which has even who have given radiation to the very young age in a very well designed prospective fashion. And it's also the first study which has even defined the post-operative margins in the terms of CTV. So it's really a groundbreaking aspect of ACNS 1 tumor, because immediate post-operative RT given to very young children, and you get a better outcome by giving radiation in the post-op setting. So thank you. Thanks a lot.
Thank you, sir. You explained very nicely all the important papers. And now I'll try to show the video that was sent by Dr. Indranil Malli. Is it visible, the screen?
Yeah, it's visible.
Yeah, I'm playing it.
Dr. Sayan, again, we cannot hear any voice. I think there is some technical
problem
issue
yeah.
that is coming. Because I also tried the same thing, like before, but I couldn't do that. But I believe you had playing well. So I think we can forego this at this time right now.
Yes. So we'll straight away go to the panel discussion then. We have to skip this. I'm sorry that we have to skip this. We are not very good technicalities of this platform. Anyway, let us move to the panel discussion, COVID-19 and cancer care in India. And we have with us today esteemed panelists, Dr. Rima Pathak from Tata Memorial Hospital, Dr. Susipun Banerjee from Vedanta Hospital, Dr. Siddharth Chakrabarty from Apollo Hospital, Hyderabad. He is a senior breast and endocrine surgeon. Dr. Sayan Das, consultant radiologist from Narayana Hospital, Kolkata. Dr. Joydeep Ghosh from Tata Medical Center, consultant medical oncologist, and Dr. Tushti Ganguly, senior consultant hematologist, Dr. Saraj Gupta Cancer Center and Research Institute, Kolkata. All have contributed in this book. So without wasting much time, I'll go to Dr. Rima first. Dr. Rima, this is a unique situation, COVID-19. We have never faced this in last 1 century. And these situations can again occur in future also. So what do you think in breast cancer management? What are the modification or what are the strategies you will like to take during this type of situation like COVID-19 and pandemic situation?
I think this year breast was particularly extremely lucky that the UK fast and fast forward studies had already published their results, and we could simply just move on from the conventional or the modestly hypofractionated regimen of 14-15 to directly fast and fast forward regimen. And again, luckily for us at Tata Hospital, we had already started treating some of our patients with fast regimen, so we were relatively more comfortable in directly switching everyone into ultra hypofractionated mode, and that is what sort of I think saved the day for us. I think everyone's aware that Mumbai has probably the highest number of cases, and it was extremely challenging to continue care with that kind of COVID situation, plus having fewer staff and fewer working hours to complicate the cancer care for our breast cancer patients. But I think overall, we have to look at hypofractionated regimen that will help us in reducing the overall treatment time for these patients. And in terms of pandemic, if you have to reduce the hospital visits, I think it is more economical on that front as well. So I think moving forward, hypofractionation, and even probably in future, maybe say 10 years from now, even single fraction treatments might be completely safe. So I think we are in a flux in terms of radiotherapy for breast cancer, and the future is extremely exciting.
So are you taking any special consent from this patient if you are using some ultra hyperfractionated regimes?
Yes, we are. We have a COVID consent form, and we consent them. We explain to everyone, for that matter, And there is barely a single soul who has ever refused to say that, no, you give me 40, 15 only, or you give me 15, 25. They are all extremely happy to receive 5 fraction and go home.
Okay, that is a very important information you have given, because in this situation, if all of us can adopt some kind of strategies, it will be very, very helpful for the patients. Many patients even do not want to complete the treatment because they are afraid of getting COVID in the hospital.
Correct.
We face this situation. So what is your advice if we do it? Because you are in Tata Memorial Hospital, you have a very good setup, very heavy center, and all the constant things and trials in situations are so well organized. But if we want to practice it outside this in private centers or in government or medical college or hospitals, what is your advice? What kind of consent on how we should go about this?
So 2 or 3 points. One is obviously consenting the patient and explaining to the patient why you're doing or why you're making a change in any standard treatment protocol. The second thing is that you need to have proper quality assurance program in your particular institute. And this means quality assurance not just of your machine, but also of the plans and QA and the processes of patient simulation. It is ultra hypofractionated, so you have to be extremely careful. It takes additional time to try and make plans that are not unnecessarily hot in some places and cold somewhere else. So one has to be extremely particular in dosimetry. Hot volumes at our centers, we try and restrict 105% isodose volumes, not just 107. So there will be barely any patient who would ever have a Dmax of 107 at our institute. So that kind of planning needs to be in place. The other thing that I would like to say is that many of these patients do not have acute toxicity right away at the end of the treatment. So especially for fast forward. So if you've completed the treatment in 1 week's time and the patient has absolutely no reaction at the end of the treatment, does not mean that that's the peak toxicity. Most of the time, the toxicity comes in at 2 or 3 weeks. And we sort of learned this later after practicing it in a few patients. And from May onwards, we've started calling our patients back at 2 weeks. And if it is not possible, if they are out, they're patients who come from longer distances and cannot make that 2-week visit, we tell them to do a video consultation with us. So I think that is extremely necessary skincare because otherwise the acute toxicities can be quite stressful in these patients, especially when you're using a not so standard regimen.
Thank you, Dr. Rima, very much. We have our breast surgeon, Dr. Siddharth Chakraborty, who is a specialist breast surgeon. I will ask Dr. Siddharth, so in your surgery, what are the modifications you are doing to combat these situations?
Yeah, coming to the breast surgery, I mean, most patients we are, if depending on the luminal, if they are luminal A, we are putting them on hormonal therapies. And if they are triple negative, we are asking them to go to chemotherapy. And if they have completed all the treatments, like they have finished the chemotherapy, then we take with all necessary precautions, we are going forward with the surgery. So, but yeah, every patient is a potential COVID. They can contact before, during, or after the surgery. We had patients who after we discharged after the surgery, they contacted COVID. And some patients during the chemotherapy, they contacted COVID. And in fact, a couple of them became serious. Fortunately, they came out of it, needed some oxygen support. So we have to be careful. I don't know how long this COVID is going to last, but yeah, every patient, you have to be careful. And even the international guidelines say try to avoid or postpone surgery if possible and put them on chemotherapy. Even for chemotherapy, they would advise giving them a 3-week course rather than giving a weekly regimens to minimize the contact in the hospital.
Do you think this situation is influencing the type of surgery also, like breast conservation versus MRM? People are people opting for MRM more than breast conservation?
Yeah, I mean, thinking like that, we haven't, practically speaking, it has not changed though. But yeah, theoretically, if you can avoid radiation, it is roughly 2 to 4 weeks of treatment. I mean, visits to the hospital you can avoid. But practically, it is not happening like that. Patients are opting. It is an individual decisions. Patients' personal preference whether they want to go for breast conserving surgery or modified radical mastectomy. But we do tell them that yeah, you can avoid radiation and possible visits to the hospital.
Okay, that is, I don't know whether like we are going backwards because of the situation, because now the whole world is adopting BCS, but the situation may be forcing us to do something else. Anyway,
Yeah.
we have Dr. Yeah, you want to say something, Dr. Siddharth?
No, thanks.
Yeah, okay. So we have Dr. Jaydeep Ghosh as a consultant medical oncologist from Tata Medical Center. Dr. Jaydeep, I want to ask you, in your chemotherapy schedule, what are the modifications you are doing?
Yeah, so it actually depends on the subtype of the breast cancer. So we had a discussion in our MDT. Patients who were luminal A, who otherwise would have gone for neoadjuvant chemotherapy, in them we have given neoadjuvant hormonal therapy. And now these patients are coming up for surgeries, and we are seeing actually partial responses in quite a number of them, although the time is quite less, around 2 months. So for hormone receptor positive, we are doing that. For triple negatives, we used to follow strictly the dose dense protocol, but we have reduced the dose dense to a standard 3-weekly regimen to reduce the number of visits. We have not come down on the chemotherapy because that would have anyways hampered their long-term outcomes because it is triple negative. And for HER2 positive diseases also, we were trying to push in chemotherapy for patients who were willing to come to the hospital, because that is also another high risk group. But for elderly and who are not, for whom coming to the hospital becomes difficult, in that situation, we were trying to see if they can take trastuzumab based regimens at home or under supervision of the local oncologist. So these are the modifications that we did more or less in breast cancer.
And for other sites, like, are you modifying the drug also, like not in breast, but maybe some other situation like which are more toxic to the lung? Are we avoiding these drugs during this situation, like PEP, like bleomycin? Are we avoiding?
Yeah, so in situations where we used to use a 3-drug regimen, we went to 2-drug regimen. For BEP, we gave EP rather than BEP because many trials have shown more or less equivalent results. So, but mostly we have tried to do away with very intense protocols, mostly in the curative setting, because in the metastatic setting there is hardly any intense protocol. So for the intense regimens, we have tried to come down on the intensity rather than the dosing, because at the back of the mind, there is always this fact that they might or might not get affected with COVID, but if the disease progresses, they lose the opportunity of getting cured. So that is one thing that from a medical oncologist perspective, we always have at the back of our mind. In fact, we did a survey where a large chunk of our patients actually wanted to continue chemotherapy despite all the problems that they had to face, logistics and everything. Almost 70% of the patients wanted to continue chemotherapy.
Okay, thank you very much, Dr. Jaydeep. We have Dr. Tushti Ganguly, who is a senior consultant hematologist. I will ask to Dr. Tushti, because you deal with more severe situation like bone marrow transplant and all this. So you might be facing many problems. What are the things, modifications you are doing in your practice for hematological malignancy patients and for bone marrow transplants?
Okay, so basically, been published up till now that the maximum cases of morbidity with COVID-19. Hello, am I audible?
Yes, you're audible.
So the maximum cases of morbidity or mortality in patients with cancer who develop COVID-19 are in patients with hematological malignancies or those in malignancies of the lung mainly. So here we are faced with a very difficult situation because in our scenario, the patients that we have are already immunocompromised due to their hematological malignancy, and whatever treatment that we give, both high dose corticosteroids, be it anti-CD20 monoclonal antibodies, and of course bone marrow transplant, is going to further reduce their immunity or cause more immunosuppression. And in this scenario, if the patient develops COVID-19, it becomes very difficult to manage. But having said that, you know, these are diseases like acute leukemia that you cannot afford to stop treatment, because the patients will invariably relapse and they'll be lost to the disease. So we are really faced with a very difficult choice as to when start treatment, when stop treatment, and you know how to organize particularly a planned procedure like bone marrow transplant. So taking the questions of Dr. Paul from the first, in case of transplants, we were very, very shaky to start transplant at the onset of this pandemic when it hit our state or our country. And you know, because see, when we are doing a transplant, it is mostly that the patient has a disease in remission and we are trying to prevent relapse. So taking a patient in remission, giving them a myeloablative or maybe a non-myeloablative even, but potentially very, very immunosuppressive therapy. And then if that patient lands up having a COVID-19 infection in this situation, it would have been a very difficult thing to manage. So for the first 2 or 3 months, we actually stopped with all our transplants. We have begun very recently, and we are going on. Our second transplant is going on. The first auto transplant we have already completed, and he's on the way to recovery. We are conditioning for the second, and you know, we are right now hoping for the best. Basically, there are no hard and fast rules, you know, for transplant that you know or we cannot do that, but assess the risk of relapse vis-a-vis the risk of waiting the pandemic out. Because when we started at first, it was known that okay, maybe 3 months, maybe 6 months, but now it doesn't seem to end. So we have to take a decision where you know we have to judge whether the patient is going to have a higher risk of relapsing with the disease. And our transplant unit is that we have tried to place those people who have developed COVID-19 infection and have become RT-PCR negative or become non-infectious, and preferentially place them in the contact with the patient and minimize our contact with appropriate social distancing, and obviously the other hand washing and everything has to be maintained in the unit as such. So with that, we are on the way of you know resuming our bone marrow transplant program, and we are going ahead and we are hoping for the best right now.
Thank you, Dr. Tusti, very nicely elaborated. Now I'll ask Dr. Sushavan regarding the gynecological cancer. What is your advice, like how we can modify our treatment plan in gynecological cancers, like especially the brachytherapy part?
So gynecological cancers, radiotherapy is mostly curable in most of the patients. You all know, especially in cervix, and it's a very important endometrium also. So in cases like cervix, we should offer the best of the treatment, and if the patient is not positive or he is not a risk to the other patient, the routine treatment should go on. And in cases like endometrium cases where there is a chance that we can omit EBRT and can do with vaginal brachytherapy, then we should go for a vaginal brachytherapy that will cause the minimum exposure of the patient to healthcare, as Rima said. And apart from that, you asked about brachytherapy. What I think is managing brachytherapy in each center is the doctor will have to manage, the team will have to manage themselves depending on local resources available, how many kits they have available for the healthcare workers, how much precaution they can take, what is the policy of the management, all those things. For me, I believe as healthcare professionals, we will have to go ahead with the treatment and we have to finish the treatment the best we can offer. Maybe we can make some modifications, like in our center, what we are doing for the cases who has a minimal disease after EBIT in cervix. So we actually are now not doing any CT planning for them. We are just doing a CRM based planning because that is within our OR and we can do it there only. The patient doesn't need to be shifted to a diagnostic CT where there are patients who are doing lung scan and all the things. But for the patient who are needing interstitial, then we will have to do all the things. There are some modifications will be based on the physician choice. Then, for example, if you are doing an interstitial, actually we have done a few, 3 or 4 within this time, and we are doing all in the single session. In cases with the checking X-ray doing or a checking CRM doing done every day, but we are finishing it at a single time. It is the same as the doses are different, but this is already being followed by Tata Memorial Hospital. They are doing already a trial on this SIMBRACE. And quite a few guidelines has also come, one by Dr. Umesh Mohan Sethi and another by Dr. D.N. Sharma on brachytherapy. But we all have to admit, and also in the ABA brachytherapy journal, other has come, but we all must understand those are all guidelines and expert opinions. Ultimately, the treating physician will have to decide what is best for the patient, while the other patients are not at risk. But at the same time, the patient should get the best treatment, radical treatment for cure, because the gynecological cancer, especially cervix, they have a chance, they are the curing for this treatment. Because COVID can infect, and COVID may or may not kill, but cervix, gynecological cancers or cancers will definitely going to kill. And as healthcare professionals, will have to take risk for the patient with all available precautions, obviously, because we are warriors here, and we cannot say from our part that we will not do this, we will not do that. Depending, if the resources are available, we have to use and have to treat the patient. That's all I feel, and we have to take the patient in confidence for all situations.
Okay, thank you, Dr. Susarman. The last question to Dr. Sayan Das. For GI malignancies like in esophagus, are you feeling that you are changing your treatment regime? Like there are options like where you can use only chemotherapy and avoid radiotherapy as a neoadjuvant treatment. Do you think these kind of modifications people are doing during this time?
Yeah, I agree with you. The evidence for neoadjuvant chemotherapy instead of NSCT-RT is mostly for adenos. So yeah, so those with adenocarcinoma, yes, that is definitely an option to avoid multiple modalities. But for squamous, again, the evidence for NSCT is not that strong. So for squamous, I think still now NSCT-RT still remains the standard. In this, I mean, as Dr. Rima said, for breast cancer, it's really fortunate those results are fast and fast forward coming up. But for esophagus, such options of hypofractionation is not really available.
Yes.
So
for colorectal, like
yes,
rectal cancers, are you adopting any short course regime?
Yes,
for rectal cancer?
definitely. For rectal cancers, we nowadays going for short course.
Right.
And unless I want significant tumor downstaging, I rarely opt for a long course chemo. With regards to esophagus, yes, nowadays I try to be really particular about my lung doses, and I try to keep them as low as possible, keeping in mind my mean lung doses as well as the V20s and the other dose volume constants that we look at while evaluating our plans. Other than that, yeah, I mean, there are hardly any significant frequent modifications associated with the upper GI tumors. I don't know, any other panelists would suggest some?
Yeah, upper GI tumor, I think there is very little scope of modification because these are not very good type of tumors that we handle. So,
Yeah,
okay, if does anyone wants to say anything, any comment or any suggestion regarding this, any of the panelists? In general, if you want to suggest something regarding the management. So if there is no, then we'll conclude here. I think it was a very fruitful discussion, and the modifications we are doing, we all are doing. We have been forced to do some modification in our treatment methods and plans. So maybe we hope that this situation will improve soon, and we'll be able to go back to our previous regime and previous things. And also we hope that during this difficult times, some new regime, some new treatment methods, some new treatment planning will also get established. So thank you everyone. Thank you very much. I thank all the panelists, all the participants, all the attendees. We have taken much time. We are like we are taken, I think, more than 30 minutes. So thanks for your patience. Thank you all. We'll
Yes, sir.
conclude here.
That was a great session, and I'm sure the participants would agree with me.
Thank you all.
Thank you all, sir.
Thank you, sir. Thank you so much for coming.